Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am so excited to be joined today by Dr. Leo Galland, who is here to talk about all sorts of things around long COVID, the two-tier model, the web of long COVID, and I'm sure loads of other stuff that we're going to get into. So a very warm welcome to the podcast today. I'm so excited to see where we end up today.
Great. I'm really glad to be going over this with you, Jackie.
So before we get into more complicated things, would you just say a little bit about yourself and what it is that you do?
Well, I have training in internal medicine, and what I've been doing for, I don't know, over 40 years now is working with patients who have complex chronic illness. Um, Basically, people who are not getting the answers that they need to get better, and trying to help them navigate the difficulties of that. And it kind of feels like what I'm doing is looking at areas that other doctors they've seen haven't paid attention to try and find solutions for their problems. And along the way, I've done a lot of work with nutrition. I've looked at the impact of the gut microbiome, and concepts like intestinal permeability and how those impact systemic health. And I've done a lot of work with patients who have post-infectious disorders or so-called post-infectious disorders. That is, they've been sick with some kind of infection, but they don't really recover. And how do you help somebody get back to their pre-illness state of health or better? I mean, sometimes when people start paying attention to their health, they actually wind up being healthier than before they got sick.
Yeah, and I can definitely say that's what happened to me, that I am healthier now than I was. So I love that that's something that you have seen in your work as well. You said that what was the term you used? The sort of post-infectious illnesses and the sort of chronic conditions, all of these sorts of umbrellas that get sort of tossed around. And all of these things existed long before COVID came along, of course, but certainly my attention was drawn to it with long COVID because that was when I became unwell. And I think that was the case for many, many people. And suddenly we became aware that, oh, this has happened before with other stuff, that a lot of us didn't really have that much awareness around it. But it sounds like you've been working in this area for a long time before long COVID came along.
Yeah. Oh, yes. Yeah. I mean, I've been doing this kind of work for over 40 years.
Mm,
When 5 years ago, well, a little over 5 years now, about 5.5 years ago, when I realized that something big was happening, I set about to start studying this virus, the SARS-CoV-2 virus, and looking at its precursors, SARS and MERS, to try and understand what happens in these disorders. And it had become pretty clear by April of 2020 that there were people who were not recovering. These were mostly hospitalized patients. Within a year of the onset, it was clear that there were people who had fairly mild illness and not only didn't recover, but sometimes got worse. That is, the sequela was worse than the actual illness for certain people. These were Many of them were relatively young and had been in pretty good shape before they got COVID. And and so one of the things that emerged, and it emerged very early on actually, was a recognition that there's something very different about this virus. Um, in fact, I remember, one of the first things that became obvious is that this looks like a respiratory infection, but it's far more than that. This virus attacks blood vessels. And I remember in March of 2020 talking to a hospitalist who was in Seattle, Washington, which had become the US epicenter before New York. And he said the crazy thing is the people that are dying in the hospital are dying from cardiovascular complications, not pneumonia. Um, and um, so as time went on, it became clear that damage to blood vessels and the resulting blood clotting that occurs is an important part of the pathology of COVID-19. It doesn't go away just because someone gets over COVID. It can linger for weeks or months, and it plays a role in creating long COVID, or what's sometimes called the post-COVID condition. And above and beyond the long COVID syndrome itself, there are a whole lot of illnesses. There are a whole lot of illnesses that have been identified to occur in greater frequency after COVID. Diabetes, high blood pressure, elevated blood lipids, cholesterol, heart attacks, strokes, seizures, conditions like that. They're not generally called long COVID because they're their own discrete illnesses, but it is very clear that COVID-19 increases the incidence of those occurrences during the year after infection. And a lot of that has to do with the damage to blood vessels that this virus creates. The other things that became clear were that the virus produces damage to cells, to the metabolism of cells, especially damaging mitochondria, which are the tiny powerhouses that generate about 90% of our body's energy. And that it also impacted the brain in a variety of ways that could not have been anticipated, that it has a range of effects on the immune system, and that it also impacts very early on the microbes living in the gut microbiome. Now, before there was ever long COVID, there were conditions like CFSME, chronic fatigue syndrome, myalgic encephalomyelitis. That name was first applied in the UK back around 1950. But there's been an awareness of post-viral illness going back as long as we've known about viruses, to the 1890s. This is just historical, tidbits, but the original post-viral illness was called the Russian flu, and it became notorious because it impacted the British ruling classes. There was a flu in the winter of, I think it was 1890, that started in St. Petersburg, spread across Europe, and really decimated people. But a lot of the royalty and the upper echelons of government in the UK were impacted by it. And during the decade that followed, there was a recurrent illness that occurred in these people who had had the flu. where they might seem to be functioning pretty well, and then they would just totally crash and be incapacitated. Um, Similar types of illness occurred after the pandemic of 1918, and again lasted for about 10 years after the end of the pandemic. And then in the 1950s, it became there was attention paid to various episodes of a, a stereotypical illness with fatigue, flu-like feelings, malaise. Low-grade fever might be part of it. Brain fog was an important part of it. Pain, and this was given different names. The initial name was Royal Free Disease because it was first described at Royal Free Hospital in England, and then another. There was an outbreak in Iceland. It was called Icelandic disease, and it soon became pretty clear that these were all probably part of the same phenomenon, but the exact cause wasn't clear. So there's an aspect of long COVID that fits into that. The difference is, in my experience, is that it's much more frequent after COVID than after other kinds of viral infections, especially among people who are young and healthy or thought they were young and they knew they were young, they thought they were healthy and fit before they got sick. And um, it comes on much faster. That is, we're seeing it evolve in real time now. In the past, someone would be ill for a long period of time and they'd see a doctor, and then you'd have to retrospectively look back and say, oh, yeah, maybe this is a result of this condition that you had. Now, in my experience with this, I found that there were a lot of people who actually were still infected. This was not especially dealing with Lyme disease or other tick-borne infections, bacterial or parasitic, or intestinal parasites, that this was not really a post-infectious state. There was an ongoing infection that needed to be treated. Treating the infection was essential, but it was often not adequate because there had been so much damage done. And sometimes the drugs that you had to use to treat the problem created their own problems. So it's always been a multi-step complex process that would vary from person to person. Sometimes it would be relatively easy to treat, and sometimes there's just layer after layer. And I described this process in a book that I wrote in 1996, or that's when it was published, um, which is called Power Healing. And it's a process of recognizing that each individual has a unique illness, and that to try and help them get through it or recover from it, you need to look at factors that I call mediators, antecedents, and triggers. What are the triggers in this person that create illness? It could be food. It could be an infection. It could be something in the environment. Mold, for example, which is a big problem in Scotland. Um, and it could be a medication that they're taking or some toxins that they're exposed to. And so you need to really try and sort all those out. Mediators um, are things. Some of them are chemicals and some of them are social that create illness. Um, there's been a lot of attention focused on free radicals in the body and inflammatory proteins, and those are mediators. But the feedback that you get from the people around you when you're ill, that can also be a mediator. So the mediators range from actually subatomic to societal, and understanding all of them is really important if you're going to trying to help someone with a complex chronic illness get totally well. Um, Antecedents are those factors in their life prior to the illness that set up the situation in which this person now does not get better in the way that we would expect them to. And so when I talk to patients, I generally go through their whole life history because what I think it's really important to understand is this is not just about a disease. This is we have to who we I want to start understanding who is the person that this happened to, and so that I can then apply that knowledge to trying to come up with treatment protocols that work. And this is not about in any way psychologizing an illness, but I mean, we're all psychological beings. We exist. We have this, we think, we feel, we have social interactions. So the whole universe of a person needs to be taken into account. Getting back to COVID and long COVID. So about 3 years ago, when I looked at all of the different factors that had been described in people who had long COVID or had not really recovered or whose lives had been altered by COVID, um, I put together a graphic that I called the web of long COVID. And um, I did it basically as a teaching tool, but also because it helped me to understand what I was looking at. And when each new piece of research would come out, I would try to place that piece in the web of long COVID, which helped me understand it better. Because, I mean, there have been thousands and thousands of studies done on the impact of COVID on the body and how it changes the body for months or longer. Um, and you can really get lost in the data. This is a way for me to organize it and understand it. And it's posted on my website, drgalland.com. We can talk about it, but I mean, there are 10 components. There could be more, but basically, when I set out to create a visual of the web, I looked on Google for where's a good web. And oh, there was a web with 8 strands. That's good, but I need a couple at the center. So I just had my son edit that. Um, there would be I could probably come up with 20 strands, but I think the 10 strands of this web pretty much describe most of what's going on, almost all of it. And it stood the test of time because everything that I described still applies. Um, at the center of that web, there's damage to an essential critical enzyme called ACE2, which is the entryway by which this virus gets into most cells. And the treatment protocol that I put together in March of 2020 was based on recognizing that a lot of the illness in acute COVID comes from damage to ACE2 when the virus enters the cells. So it was basically how do we restore ACE2 activity, which with natural products, vitamin D, curcumin, which is found in the spice turmeric, resveratrol, well known as an anti-aging supplement found in red wine, and a few other supplements like that that help the body restore ACE2 after it's been damaged. And my personal experience is that of the patients that I've treated from the beginning of their COVID, because they were my patients over the past 5 years, almost none went on to develop long COVID. Really, I mean, hardly anybody. Um, and I would track and follow them. So I do think that ACE2 restoration was important. the second central part of the web is mitochondrial damage. We know that this virus damages mitochondria. Now, any kind of inflammation may do that, but this virus does it beyond the effects of inflammation and infection. It directly damages it, and it impairs the ability of mitochondria to regenerate themselves. So mitochondria use a lot of oxygen. They're very high risk tiny organelles. And in order to work well, they have to be broken down and rebuilt constantly. And it was shown very early on that what this virus does, and it's due to the viral proteins themselves directly, is to impair that process called mitophagy and biogenesis. That's impaired, in addition to the other types of damage that are done. The levels and mitochondrial damage has a huge impact on the post-COVID state, especially when there's fatigue involved, sometimes shortness of breath. The other strands of the web that go out from that include the damage to blood vessels and the microscopic blood clots that and also the disturbances in the gut microbiome, which are a direct result of what this virus does in the GI tract. They're not studies done with chronic fatigue syndrome and with CFS-ME have shown that people who have been sick with CFS-ME develop a dysbiosis in the gut with a leaky gut. This happens right away with COVID. It doesn't take a year of sickness or 2 years, or it happens immediately in people who get COVID. And so the issue there is to restore the microbiome as quickly as possible. Part of that involves restoring ACE2, because ACE2 in the gut is important for immune responses there. And these immune responses regulate the microbiome. But part of it is that you just have to restore a healthy gut bacterial population, because the virus, and this has been demonstrated following people, the virus devastates one of the most important bacterial species that's kind of a keystone species and supports a lot of other species. And most people have never heard of this. It has a hard to pronounce name, Faecalibacterium prausnitzii. You can't buy supplements of this, but it supports the growth and activity of bifidobacteria that then secondarily get depleted. So restoring the gut microbiome is a second after ACE2 and probably the second most important thing. And there actually are probiotics that have been shown to help with COVID-19. So there's one that that we get through a pharmacy, I think in London. But it's made in Spain, called AB21, that in a controlled trial was shown to help people with acute COVID recover faster and better. It's based on a type of organism called Lactobacillus plantarum. Now, Lactobacillus plantarum, as its name implies, it's like an acidophilus. It's a lactobacillus, and it grows on plants. It's found in sauerkraut and kimchi. There's specific strains that are used, but fermented foods can be helpful in that area. And
we'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us.
Then there's the issue of viral persistence. There's so many studies that have indicated that after COVID-19, this virus does not leave your body. The unresolved question is, are we just dealing with viral debris that is still in the cells of the body, or is there live replicating virus? And there's research that needs to be done in that area, because the approach would be somewhat different if there's live replicating virus. You may need to be able to kill it. And so all of those strands then leave us with the remaining strands of the web, which involve disturbances in immune function. And there are many different types of immune cells that are impacted by the strands that I've just described. There are T lymphocytes and B lymphocytes and monocytes and macrophages and mast cells. And for many people who are really stuck and really sick with long COVID, mast cells are the 800-pound gorilla in the room. You have to, and there are mechanisms by which mast cell activation occurs after COVID that you can trace to what the virus is doing in the body, directly or indirectly. And I would say that of the people who are most have their lives upended the most, mast cell activation is one of the factors that really needs to be dealt with. And there's an association between mast cell activation and two other things that are pretty common in long COVID. One is autonomic nervous system dysfunction, especially this condition called POTS, which stands for postural orthostatic tachycardia syndrome. That is associated with mast cell activation. And there's some studies indicating that the mast cells may actually be producing it for some people, because when you block mast cells, you can diminish the symptoms. Not for everybody, though. POTS itself, there are 3 different types of POTS. And there are other types of autonomic dysfunction that are mistaken for POTS that may occur. But that's a major complicating factor. And also related to mast cell activation is damage to connective tissue. And so there's this other association of mast cell activation that's getting some attention, which is the association with joint hypermobility. And what has been striking to me, even before the pandemic, when I was dealing with people who had post-Lyme syndromes, was the large percentage of them that had hypermobility syndromes. That's become even clearer. Now, I hadn't seen that with CFSME before. Maybe because I wasn't looking for it, but nobody was reporting that. There were reports of autonomic dysfunction with CFSME, but it was a different type than POTS. It was something called neurally mediated hypotension, and researchers at Johns Hopkins in the US at first described it, where there'd be a drop in blood pressure on standing with a lack of an appropriate heart rate response. So this was different from POTS. I started seeing a lot of POTS and a lot of hypermobility in patients who had not recovered well from Lyme disease. So there was clearly something about those conditions that was maybe predisposing to the post-Lyme inflammation, but it's coming out even more so in the long COVID population. Now, it may also be that we have a much larger population now, because there are probably 400 million people around the world with long COVID or post-COVID syndrome. And so, we're those of us who see the patients who are not getting better are going to see way more of this combination of factors.
Yeah.
So what I have done over the years is to try and put together protocols for dealing with each strand of the web. And, sometimes they work great and sometimes they don't, and which I think is the unfortunate experience in dealing with this disorder. What has absolutely emerged as the most troubling and debilitating component is something called PEM, post-exertional malaise. I think PEM is a totally inappropriate name. This is not post-exertional malaise. This is post-exertional agony. So post-exertional symptom exacerbation, or PES, is probably a more reasonable term for it. And I mean, this is one of the hallmarks of CFSME. It is so much worse in long COVID than I ever saw in CFSME. I mean, it's at a level of intensity that is much greater than I'd seen. And also, there are people in whom um, too much cognitive activity will produce physical fatigue now. The crash may be physical after just mental activity. I didn't really see that before with CFSME, but I see it a lot in the post-COVID patients. Or the physical activity, it crosses over. In other words, you do too much in one area and it crosses over, it affects the other major area of functioning if we separate physical from mental functioning. And again, that's very variable. I have some patients who can handle cognitive activity if they're lying down, and others who can only handle a social interaction for like 30 minutes and then they need to take a break. It is possible to recover. I have had patients who, when I first spoke to them, I had to actually speak to their partner. They weren't able to directly communicate. They'd be lying down in bed. And some of them now are, would I say they're 100% well? No, but they're getting about their lives. They are no longer, they move from being bedridden to being house-ridden to being able to interact outside, to start work, to go back to school. There's always, it's a long multi-step process. It is possible to recover substantially, no matter how bad the situation is. But I think you have to deal with every part of the web and maybe even some factors that are outside the web.
We'll be right back.
Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much.
Yeah, I mean, that does seem to be the pattern that I've seen myself and that I've seen in others that are recovered. It doesn't always look the same for everybody because, as you said, everyone's life beforehand was different. They came in different. Their presentation of the illness looked different, and their presentation of long COVID itself looked different. But everyone finds their own way through it. And, there's a lot of commonalities, I'm sure, between a lot of people's journeys, but they're all going to be subtly different. And, that's what makes it so difficult, isn't it, as a patient, and I'm sure as a practitioner as well, is that every patient is different. But that's also why it's so important to be able to look at each individual patient as an individual patient rather than, one of many and oh, you just do this and then this and then this and then you'll be fine. It's just not that simple, is it? And having all of those strands of the web.
Right. And that's what's very disturbing about what's on the internet is you have people claiming, oh, yeah, just do this. This is what you need to do. And well, look, people have been, before there was an internet, people were bringing me, patients would bring me ideas. Well, what about this and what about that? And okay, well, let's try it. Let's see if the first question is this rational? Does it make sense? What do your gut instincts tell you about how this might apply to you? Do you want to pursue this? If you do, and I think it's rational and reasonable, I'll go out on that limb with you. I'll go down that path and try to guide you, um, so that what are the potential problems you might get into? Aside from that, now you're going to put your energy into this instead of something else. The There's just a lot of that out there now. And some of it is valid will work for some people. I mean, my general rule is if something's a one-off, I'm not that interested in it. If I first want to know that it helps a patient that I know so that I feel that I really have the full picture. Um, because a lot of the reports that are out there, circulating, you don't really know the whole picture. You get a little snippet, and that's not enough. And then the second question is, does it work for more than one person? How many people, and once you've done it, how long do the benefits last? And what are the areas that benefit? And I mean, there just simply is no one treatment that works for everybody. I wish there were. It would make life a lot easier. If it
Yes.
were just a question of, well, there's really a chronic viral infection and all you have to do is treat it, find the right antiviral drug and treat it. Yeah, that would make life much simpler. There's just no evidence that that's the case.
Yeah. So it comes back to this jigsaw puzzle or the web, as you've described it, the different bits for different people and addressing different strands of your web is going to have more impact on some people and other strands are going to have more an impact on others. And I suppose that's why you have, a number of different things, isn't it? Because you can work out, okay, where are we going to start? Where are you going to get the biggest bang for your buck? What else is going on? What actually is going to work for this individual person? Because it might be that, certainly my experience, some of the things that helped me later on in my recovery wouldn't have worked at the start because I wouldn't have been able to tolerate them, but they worked absolute wonders further down the line. So, I think certainly for a lot of people that I've spoken to, it's finding the starting point and then allowing yourself to kind of build from there. And that is going to be very different for different people, I think. Um, I want to go back to where you were talking about the ACE2, because, you said in the center of your web, you have the ACE2 and you have the mitochondria. And I think a lot of people have heard about mitochondria. Mitochondria, they're the powerhouse of your cell, going back to my GCSE biology. And we know a little bit about them. I think most people understand, certainly in some part, the role of the mitochondria. But the ACE2 being right in the middle, they're obviously incredibly important. So what are they, and how do we go about restoring the ACE2?
Okay, right. So I want to say more about mitochondria also. They are incredibly complex. Um, so ACE2 is an enzyme that is present in many different cells, and it mostly is involved in restoring balance after there's been injury or inflammation. It's this kind of corrective response. That is, the body has a response to injury and infection and attack. But that response has to be brought under control, because otherwise you're going to wind up doing more damage to yourself than the infection alone might have done. So ACE2 is a part of that corrective response. And it's important in the brain. It's very important in blood vessels and on cells of the immune system, and in the kidneys and the heart. A lot of the complications of acute COVID-19 can be traced to damage to ACE2 done by the infection. In the earliest days of the pandemic, there was this notion that, well, ACE2 is bad because it's letting the virus into cells. And so we have to try and block ACE2. And that was, in fact, my thought when I first was reading about it was, okay, well, what are the things that would block ACE2? But then I looked at the experience in SARS, which also uses ACE2 to get into cells, and it became very clear that ACE2 is the victim, not the cause. And what you really need to do is to strengthen it to help recovery. So there are dietary effects, but I would say the easiest thing to do, vitamin D definitely increases ACE2. I'd mentioned curcumin and resveratrol. There are just a number of herbs and spices that will do this as well. In general, let's just say eating a diet that is rich in fruits and vegetables, and doing the stuff that everybody knows you should do. That helps ACE2. Exercise tends to help ACE2, but that's a very dangerous thing in the setting of COVID-19. It really is a two-edged sword. Yes, you want to avoid deconditioning and you want to maintain strength and stamina, but I have seen so many people who totally crashed after a judicious amount of exercise. I mean, sometimes they overdid it, but generally they weren't overdoing it. They didn't think they were overdoing it, but it really brought them down, and it could take weeks or months or longer for recovery. So I have a theory about that phenomenon that I developed, which relates to mitochondria, actually. So we'll move over to mitochondria. Mitochondria do a lot of different things, part of which is to generate energy. And they generate energy through two different complexes, enzyme complexes. One is a set of enzymes called the Krebs cycle, which probably most people heard about at some point in school. And the other is something called the electron transport chain. This is where the ATP is generated. And the electron transport chain, frankly, is not easy to understand. I mean, I had to spend a lot of time trying to figure it out. My medical education did not really, and the biochemistry that you have to take in college to go to medical school, none of that really it allows you to understand the electron transport chain because it involves physics. But in this whole process of what goes on between the Krebs cycle creates certain products that are needed by the electron transport chain, okay, to generate ATP. But there are fuels that have to drive the Krebs cycle. And those fuels come mostly in the form of sugars or the breakdown products of sugars, like pyruvic acid, pyruvate, they come from sugar, or fats, and the simplest of fats, the breakdown products of fats. Now, I mean, we could say a lot about that. The idea that, oh, we're just going to use a mitochondrial support product. Well, maybe that's going to work. Maybe it isn't. Maybe it's going to make it worse. There was a team at the University of Pennsylvania that developed a mitochondrial support product that worked in mice when they first had COVID-19. They injected the mice with this, and the mice that got it had a better outcome than the mice that didn't, which is impressive. I got a pharmacy in New York to put that together, but that's for acute COVID. When you're dealing with long COVID, maybe that's going to work, maybe it isn't. When there's post-exertional malaise, that's where the real issue comes up. There's a lot of evidence that what underlies post-exertional malaise is first the circulatory impairment that is part of long COVID. So there is not enough blood getting to certain tissues because of the damage to blood vessels, the capillaries in particular, that have been done by COVID. You can't see this, you don't directly, it's very hard to measure it directly, but there's all these microscopic clots and these damaged capillaries. So then you stimulate the tissue. Either you try to exercise and your muscle needs more blood, or you're using your brain and your brain needs more blood. It's not getting everything that it needs. So it creates a state in which you're working without quite enough oxygen and perfusion of blood to the tissues that need it. This creates a condition that I call relative hypoxia or relative ischemia. Hypoxia is lack of oxygen. Ischemia is lack of circulating blood. When that happens, the mitochondria that have to work hard start doing really screwy things. Some of the enzymes go backwards. Instead of the Krebs cycle going in the direction it's supposed to go, it starts running backwards. This generates further damage to the mitochondria. So what we need is a treatment protocol that can help prevent the damage caused by the fact that the mitochondria run backwards, not just mitochondrial support. We also need a treatment protocol that's going to improve the oxygen delivery to tissues. So you have to address the blood vessel damage and the microscopic blood clots. That's essential. Then, if the person has post-exertional crashes, then you can't just do a general mitochondrial support, which frankly might even make things worse, because it may stimulate mitochondria in the wrong way. You need a very carefully scripted approach to improving mitochondrial function. I describe what I've worked out, it's a work in progress, in this document on my website called Long COVID Prevention and Treatment. And I'm just putting it out there for people to see. And sometimes what you need isn't even a substance. It might be red light therapy at the right frequencies. The wrong frequencies can make things worse. You need the right frequencies. And this is not so easy to arrange. It might be what's called hydrogen water, which is water that has a high hydrogen content. There are fairly easy ways to produce that. So I would say that that's been, in terms of a research focus for me, that's been what I've been focusing on, that aspect of things over the past year or so, which is how can you put a protocol together that is not going to make the post-exertional malaise worse, but can actually allow people to slowly begin to increase their activity and recondition themselves.
Yeah. And I'll make sure that I link that document on your website in the show notes as well. So if anybody does want to go and read through that, although I don't know cognitively if everyone will be able to do it, but it's there.
Right. There's supposed to be an AI component, and I'm going to try to expand that just to make it easier. In fact, the first version of this, some of the feedback I got was, well, if you have long COVID, there's no way you can understand this. I mean, it is about 90 pages, but so in the second version that went up a few months ago, I tried to address that. We tried to address that by having different tiers. So there's a simple, like this is the simple approach, and this is the more granular approach that maybe, you need to discuss with somebody else. Um, but on the other hand, I've had not everybody with long COVID lacks cognitive, um, lacks the ability to maintain cognitive activity. It's really it's the stamina. You're good for 15 minutes, but you just run out of gas after that. And there are researchers at Yale actually who have attempted to address that with medication and supplements. The problem is I've looked for drugs that would be kind of like magic bullets, and they just don't seem to really work. They have side effects or reasons why they can't be used. Occasionally, maybe one patient out of 20, these drugs actually do make a difference, but there's just been nothing that, oh, this works for everybody.
So it comes back to that model of piecing it together, doesn't it?
Yeah.
And what you were saying as well about with the mitochondrial supplements, actually, quite apart from not helping, it might actually make things worse. I think this is a word of warning for people who are taking supplements to make sure it's directed rather than the scattergun approach.
Just one example, like coenzyme Q10. When people have fatigue with acute COVID, I really like coenzyme Q10. A lot of people respond well to it. Doses up to, from anywhere from 100 milligrams to 600 milligrams in a day. There are two different forms of CoQ10. There's the oxidized form called ubiquinone, which was the original supplement, and then there's the reduced form called ubiquinol or CoQH. Now, there's a lot of which is much more expensive. So there's this idea that, well, CoQH is a much better form, the ubiquinol. It's not really true. If you have too much CoQH, too much ubiquinol, it actually screws up the electron transport chain. The ratio of ubiquinone to ubiquinol is very important for the beginning of the electron transport chain. So I tend not to jump in with that unless I can identify certain problems in certain areas. And similarly, the NAD, a form of vitamin B3, has gotten a lot of attention. Well, just giving people NAD is not necessarily the solution to the energy problem, and it could make it worse. Because if you start, and it's a big trend in the US, people are getting injections and infusions of NAD, very expensive, but especially big in Hollywood. If you start giving people lots of NAD, the rate at which their cells break down NAD increases. So you actually can create a dependency on it by using very high doses. And certain cells in the immune system and in the brain, they don't really even respond to external NAD. They need to be able to make their own. And so what are really needed are the precursors of NAD, but they don't necessarily get where you want them to get. So it's not, so there's a lot of hype out there about, oh, this is the treatment. Well, yeah, there may be something to it. There may even be some science to it, but you really have to apply it in a thoughtful and judicious way. And I try to help people do that with this document.
So yeah, it comes down to, there being so many things out there, and being targeted and knowledgeable and trying things, but also understanding the sort of benefit versus whatever the opposite of a benefit is.
Then you have the people who have a kind of political point they want to make. Like they say, it's all about the spike protein. See, if you make long COVID, a spikeopathy, as they say, well, then, that fits right into the anti-vaccine politics because it's all the spike protein. It isn't all the spike protein. That's been very well established. The other proteins from the virus can actually be more toxic than the spike. Maybe that's a component. You can go with that, but it is not all about the spike.
Yeah. And, it's not all about anything, is it? That's kind of where we started this conversation, and we've now come all kind of full circle all the way around. There may be similar things at the root of it, but what that presentation looks like is going to be different in each person, and which means that it's not all about anything. It's piecing together that puzzle or those strands, whatever your particular visual. I'm a visual person as well, so I love the strands and the web and things. My brain has a bit of a flow chart rather than a web, so that's what's going on up here. But yeah, it's piecing that together. Yeah. Well, thank you so much. I feel like I need to go and draw it out somewhere to make more sense of everything.
Well, send me your flow chart.
Yes, I will. And I'll make sure that those links that you mentioned go into the show notes. So yeah, thank you so much for giving up your time today. It's been fascinating.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch. I'd love to hear from you.